This is Dr. Saad in front of you, and today my topic is the management of the Crohn's disease. Basically, we have discussed detail in our pathology lectures about the Crohn's disease. So today we are going to discuss its management. So first of all, in the management, we are going to do the investigations. What are the investigations you are going to do in the Crohn's disease? First of all, we are going to do the CBC. Why we are doing CBC? Because in order to rule out the anemia in the patient. Then the second thing that we are doing is the ESR and CRP. This is done because these are the inflammatory markers and they are obviously increased. Then the third thing we are going to do is the anti-Saccharomyces cerevisiae antibody, because this is basically positive in the Crohn's disease. Clear? And I told you that in the ulcerative colitis, the P-ANCA is positive in the ulcerative colitis. Then the fourth thing we are going to do is the small bowel follow through. As we are doing the barium swallow, so same is that the small bowel follow through or small bowel barium follow through is done in the Crohn's disease. Then the fifth thing we are going to do is the CT scan of the abdomen. CT scan of the abdomen. And why we are doing the CT scan? In order to rule out any complication like perforation, like abscess. So this is done in order to rule out these conditions. Then we are going to do the endo-anal ultrasound or the MRI pelvis. Why we are doing this? This is done in order to rule out the perianal disease. What are the perianal diseases? Like the fissures, like the fistulas, like the anorectal abscesses. So remember this thing that these perianal diseases, they are very specific feature of the Crohn's disease. They are more common in the Crohn's disease. So these are basically the investigations we are going to do in order to rule out the Crohn's disease. Yes, the last one that is also remaining is the colonoscopy. Colonoscopy. On the colonoscopy, what you will see, basically the deep ulcers can be seen on the colonoscopy, bleeding can also be seen. Then you can also see the patchy involvement. But therefore, the patchy involvement is also a very specific feature of the Crohn's disease that we have discussed already. So that feature you can find on the colonoscopy. So in order to rule out those features, we will do the colonoscopy. So these are all the investigations that we are going to perform in the Crohn's disease. Now we are moving on with the treatment. Okay, I'm writing it here. Treatment. What is the treatment of the Crohn's disease? Basically, we are moving on heading wise. First of all, the first thing is the induction of remission. Induction of remission. Now, what does this mean? This means that first of all, the patient comes to you. What drug that you will prescribe him in order to decrease his symptoms, sign and symptoms. So remission means, remission phase is the phase where the sign and symptoms, they are decreased. So in order to decrease the sign and symptoms, what drug you will give? So remember one thing, that the mainstay of the treatment of Crohn's disease, either it is mild, moderate, severe, whatever it is, the mainstay or of the treatment is the corticosteroids. So corticosteroids, they are the mainstay of the treatment, and very specific is the prednisolone. Clear? So that you will you will prescribe to the patient, you will be prescribing prednisolone corticosteroid to the patient. If the patient is very severe and he is not responding to corticosteroid, then the second drug that you will give to the patient is the infliximab. Infliximab or cyclosporin A. Immunosuppressants. So this is anti-TNF. they are immunosuppressants that you will give to the patient if they are not responding to the corticosteroids. Clear? Now one thing more here, if the patient is coming to you and you have diagnosed him that he is having the Crohn's disease involving the ileal portion. Ileum means involving the ileum. So the drug of choice for ileal disease, drug of choice for ileal Crohn's disease or ileal's disease is also corticosteroid, but a specific corticosteroid, that is the budesonide. This is a specific corticosteroid drug of choice for the ileal disease. But normally you are giving the normally which steroid is given? Prednisolone. But if the ileal involvement is there, then you will be giving the budesonide. Clear? So this is that how you will start your treatment. Induction of remission, main stage of the treatment, mild, moderate, severe, all the corticosteroid not responding. If the patient is not responding, you will be giving infliximab, cyclosporin A, and drug of choice for the ileal disease is the budesonide. Now the second heading, that is the maintenance therapy. What is the maintenance therapy? The second thing that you are going to do, maintenance of the remission, you can say. So second is the maintenance therapy. Maintenance therapy basically in the Crohn's disease is given by thiopurines, specifically azathioprine. Clear? So you will give this to the patient for the maintenance therapy. Maintenance therapy means maintenance of remission. Maintenance remission means that now the patient has come to you, you have prescribed him the drugs that will decrease his symptoms. Now those drugs that will prevent the patient, or those drugs that will be preventing from the recurrence, that is called as the maintenance therapy. So this drug you are giving azathioprine, this will be preventing the disease recurrence. Clear? So that is called as the maintenance therapy. Induction means that first of all you will be giving those drugs that will decrease the signs and symptoms, and after that you will be giving those drugs that will maintain that therapy, maintain that remission phase. So the maintenance therapy include the thiopurines, azathioprine, and as well as methotrexate is also used in these cases, but then the pregnancy must be avoided. The methotrexate is also used, but pregnancy should be avoided then. Clear? So this is the maintenance therapy. Then the third thing that you are going to do in the Crohn's disease is you have to treat the fistulas and the perianal diseases. Clear? So these are the complications basically, the perianal disease and the fistulas, how you will treat them. Remember one thing, that the mainstay for the treatment, the primary treatment, is the surgical treatment. What are the surgical treatment for the fissure, fistulas, hemorrhoids, whatever the treatment is, the surgical treatment we will study in the surgical lectures. But remember this, that there are certain medical therapy that is also given in these cases. So remember one thing, that the enterocutaneous fistulas, they respond to infliximab and adalimumab. So they are responding to these drugs, means these drugs, infliximab, adalimumab, they are basically anti-TNF drugs. So these drugs, they helps to heal these fistulas. Clear? So these drugs helps to heal these fistulas, and if in case these fistulas are not healing, then obviously you will go with the surgical procedure that we will be discussing in our surgical lectures. But here the medical therapy is the infliximab and the adalimumab, and we can also give the antibiotics for the perianal diseases like the metronidazole. They can also be given. But you can say that after these medical therapy, the mainstay of the treatment is obviously the surgical treatment. Clear? So after this we have the surgical treatment. When the surgery is indicated in these cases, very easy, surgery is indicated when the medical therapy fails. Clear? And when there are complications like the fistulas, these perianal diseases, so the surgery is indicated in those cases. Surgery is also indicated in the children who are not responding to the treatment and who are not growing, means the children, their growth is not good after the medical treatment, then you will also do the surgery in those cases. So these are the indications for surgery. So basically this is the treatment for the Crohn's disease. Now I would like to tell you the side effect of the certain drugs that we are using in the inflammatory bowel disease. So then we will end the lecture. Now I am telling you the side effect of the drugs that we have used in the inflammatory bowel disease. See now, side effects of drugs used in inflammatory bowel disease. Now we have used the drugs in the remission phase, that is the mesalazine, that is basically 5-amino salicylic acid. So you must know the certain side effects of this drug also, that are simple headache, diarrhea, there may be developed nephritis may also develop in the patient. Then there is the reversible infertility in males. So remember this thing, that 5-amino salicylic acid can cause the reversible infertility in males, means when you will stop the drugs, the fertility will again be normal. So that's why that is the reversible infertility. Other side effects are the headache, diarrhea, nephritis, and these all. Then the second drug that we used in the inflammatory bowel disease are the steroids. There are many side effects of the steroid, and that will be detailed discussed in the endocrinology, but here I would like to tell you certain side effects also. See, there is proximal myopathy may also be developed in the patient for using the prolonged steroids. Then the steroids may also have the skin strias may also develop. Then we have the anxiety in the patient, depression may also develop, hypertension may also develop, osteoporosis may be developed in the patient, hyperglycemia may develop, you can say natremia may develop, hypokalemia may develop. So these are all the side effects of steroids, but basically the steroids in the inflammatory bowel disease, the steroids, they are not used for the prolonged period, they are only used in the active phase. Like I told you, in the Crohn's disease we use the steroids in the active phase, induction phase. For the maintenance phase, the steroids are never used. There is no role of the steroids in the maintenance of the remission. So these are the basically side effects of steroids. Then the third thing is the immunosuppressant therapy. Immunosuppressant therapy, we have the azathioprine, and we have certain side effects like the pancreatitis, like leukopenia, that is associated with the azathioprine. Then we have the anti-TNF. Anti-TNF basically like the infliximab that is used in the anterior cutaneous fistulas, like the adalimumab we used in the anterior cutaneous fistulas. So they are also having the side effect. One of the most important side effects that I want to tell you is the reactivation of TB. This is very important, that before starting the anti-TNF you have to check the patient for the TB. You have to do the workup of the TB before starting anti-TNF, means you have to do the X-ray, you have to do the TB testing in the patient before starting anti-TNF, because these drugs can cause the reactivation of TB. Why? Because these drugs can cause the reactivation of TB. So that's why this is very important point. While other side effects we are also having, like the arthralgias and other side effects. So just you have to remember, this is the main that you have to remember, and anti-TNF we will study in our further lectures also, like in the rheumatology the anti-TNF also used. So there also the reactivation of TB is the side effect. So remember this thing, that reactivation of TB is the side effect of the anti-TNF drugs. That's why we have to do the workup for the TB. So these are the basically drugs and their side effects that are used in the inflammatory bowel disease. If you have any query, any confusion, you can ask in the comment section. Thank you so much. Allah Hafiz.